Welcome everyone to tonight's webinar, A Schema Therapy Understanding of BPD. I'd like to begin by respectfully acknowledging the Wurundjeri Woi-wurrung people of the Kulin Nation, who are the traditional owners of the land on which I stand and I'm hosting from today. In the spirit of reconciliation, NEA BPD Australia acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people attending today. We also acknowledge people with lived experience of mental ill health and recovery and the experience of people who have been carers, families and supporters. You probably all know me by now. My name is Belinda and I will be your host today. I work and volunteer for NEA BPD Australia in our virtual head office, and I am also a trained volunteer family connections leader. As you may know, we are a not-for-profit organisation and we deliver programs, webinars and events to support families and carers and people in a relationship with someone who is experiencing BPD or has BPD traits, whether there is a formal diagnosis or not. Our main offering is the Family Connections program, which is a free evidence-based 12-week program delivering psychoeducation, skills training and support for people who are caring for or in a relationship with someone with BPD. I will put a link to our Family Connections program later on in the webinar, and you will be invited to register if you haven't already. Today, we are so grateful for a presentation from Chris Hepworth. Chris is a clinical psychologist and an accredited advanced schema therapist, trainer and supervisor from Perth, WA. He has a small private practice and he's also a clinical lead on the DBT teen program in WA, within which he provides clinical consultation and guidance to DBT group clinicians and to Lifeline about clinical aspects of the program. Thank you so much for making the time for us today, Chris, and our audience. Welcome.
Thank you very much, and good evening, everybody, or probably a quite late evening, depending on where you are. Let me share my slides with you all. Okay. Okay. That's the correct way around, isn't it, Melinda? Good. Okay, great. Okay. Yeah, so look, it's my pleasure to be with this evening to give you a brief schema therapy perspective on borderline personality disorder and specifically helping somebody who happens to meet the criteria for that diagnosis. I'm not going to say too much about who I am. Like Belinda said, I'm a clinical psychologist though, and I am very, very passionate about what I do. I am both an advanced schema therapist and a trained DBT clinician. I have lots of experience delivering DBT programs, as well as other forms of therapy. And I know some of you in your questions were interested about the different forms and how they might be different. My personal view is that they're all very complementary and no one therapy is the correct therapy for everyone. And a lot of the time it's about somebody might require or benefit from different types of therapy, possibly just because they're different types of personality or the different stages that they're at in their journey. So it's my pleasure to be able to talk to you about this evening. Just going to give you a brief overview of what I'm going to tell you. So I'm going to give you, without boring you too much, the underlying theory of schema therapy, because I think it's important that you know why it does certain things the way that it does it. Obviously, then I'm going to really focus on the schema therapy angle of how we understand borderline personality disorder. And I'm going to talk to you about the different ways we try and help somebody with that diagnosis from a schema therapy perspective. Showing you in particular something called imagery rescripting, so you can get a visual understanding of what that part of the treatment looks like. And then I will make sure that at the end we have at least 10 minutes for questions, but I will keep an eye on the clock and try and aim more for the 15-minute mark or so. I'm going to skip this so that I've got plenty of time for the other stuff. So let me begin then by just telling you about what the foundations of it are and why it was created in the first place. So look, schema therapy was created by a therapist called Jeffrey Young. And he was actually a cognitive behavioral therapy, therapist. Some of you may have heard of that. It's one of the most evidence-based treatments, and it's been around for a long, long time. And it's where people kind of try and change the way that they're thinking to try and change the way that they're feeling. So we really examine people's thinking patterns. And it's very effective for a lot of things like depression and anxiety. So Jeffrey Young was actually a cognitive behavioral therapist under one of the masters of the trade called Aaron Beck. And essentially, look, what he was finding, though, was that there were certain limitations to it. So he was trying to apply cognitive behavioral therapy for all the people that he was working with, and was really finding that in certain areas, it wasn't that effective. It was kind of coming up quite short. And one of the particular areas that it wasn't really being that effective was in trying to help people with borderline personality disorder. So one of the major things that he was finding was that, basically trying to change the way that you think doesn't always change the way that you feel. So you may have this experience yourself or from the people you know and care about, where they may say something like, I know, logically, intellectually, that what you are saying is true, but it just doesn't feel that way to me. My emotion feels different to what you're telling me is the case. And a big reason for that is that if things are kind of created in emotion, we often need to change them with emotional techniques. And part of that as well is that not all patterns, not all things in our life that affect us is verbal. So some of the things that affect us are kind of subconscious and pre-verbal. So some of the things that happen to people and affect them and their personality may even happen before we really start to form a lot of conscious memories. So below the ages of 4 or so, yet it still can impact upon us. And the other big thing that he was finding was that there was a lot more interpersonal difficulties when he was trying to help people with borderline personality disorder than, say, his other clients who didn't have that. Both in the therapy, so there'd be a lot more tension, a lot more ruptures and difficulties between him as a therapist and the people that he was trying to help. And he was also finding that there was a lot more ruptures in their wider life than, say, people with depression or anxiety. So that was his original view. He was kind of trying to do CBT the best that he could for people, but was just finding that it's for not everybody, it just didn't quite cut it. So he created schema therapy, and schema therapy is a cognitive behavioral therapy. So all the techniques we actually use in CBT, we can use in schema therapy too. But there's a few kind of major differences. So schema therapy was created originally to help people with borderline personality disorder, although it's what we call a transdiagnostic model. So it can actually help people with lots of different problems, including people who don't necessarily meet the criteria for a personality disorder or who have any other active mental health kind of symptoms at the time, but maybe do have patterns that are quite rigid and quite strong that need changing. But one of the things in schema therapy that's very different to, say, CBT is that there is a much greater kind of emphasis then on emotion. So as you'll see later on when I show you imagery rescripting, we are really trying to get people to feel things in healthier ways, and then very deliberately using emotional techniques to provide healing. So affect, emotion, is a core component of schema therapy, whereas with CBT, it's all about thinking. And if, say, we contrast it to DBT in what we call stage 1 of DBT, DBT is very much about behavior and skills and changing the things that we do. So that's the first major thing, is there's a real focus on emotion. The second thing then is there's a real emphasis as well on the therapeutic relationship. So the relationship, say, between myself and my client, the person that is seeing me on a given session, is important. And it's actually part of the vehicle for change. So basically sitting with them and being an attuned, warm human being who is also, though, prepared to tell them some hard truths when they need to hear it, is also part of the healing. So what happens in the session between us is also really relevant. So they're two of the major things that differ, say, from CBT, that the relationship is important and is an active vehicle for trying to help. And we really do focus a lot on emotion. Schema therapy, similar to many therapies, say like DBT and other therapies, is a more longer term therapy. Because if somebody has these, quite long-standing problems, it's very simply going to take quite a long time to heal. So this is not something where you can come and see somebody for 10 sessions and expect that things are going to be very, very different. Schema therapy, similar to DBT, is a therapy that, to be effective, can take a year or a few years of therapy to really, really help make shifts that last for people. And a couple of the other very important things is the idea of universal emotional needs and what we call early maladaptive schemas. So the universal emotional needs, okay, broadly, there are 5 categories of emotional needs. So this can be different to physical needs and stuff like needing a roof over our head, but these are needs which are there from day zero and actually do affect kind of who we are as we grow up and as we get older. And they are universal. I always tell my clients that there's nothing in these needs that say that, Chris doesn't count or he doesn't have these ones, the same with them. So they apply to everybody. So the first emotional need is attachment. Attachment basically is the very first need in life, and is usually with your parents, but it could be a caregiver, depending on your personal circumstances. But that is where we do feel seen by somebody. We feel that they really try and understand us, that they clearly accept us and like us, and also, when need be, that they keep us safe. So attachment is all about connection, particularly between that baby and as we get older, and usually a parent. Second need is we also need to develop a sense of identity. So we need to understand who we are. So one way that this is not met is if actually we really don't know who we are, if we feel like we just have no sense of identity, or if we feel like that needs to change depending on who we're with, maybe to keep them happy, to make people pleased with us. We also need to grow up feeling competent, so feeling like we can do things well enough in life. Doesn't mean we do things perfectly. Quite the opposite. In schema therapy, it's about being good enough, but that we do feel like we can do things. And it can also be about the way that we're given feedback. If we're given feedback in a constructive way where we're likely to learn, or if we're treated, say, with quite a lot of harshness when we get things wrong. And then the last thing, and the second broad need, is we also need to be able to develop independence. So we need to know that although we have attachment to people and we can go back to people and rely on them, that we can stand on our own 2 feet, that we can do things in this world by ourselves when we need to. The third need is we need to be able to express our emotions and our needs, and for them to be validated. So it's not enough for someone to say something like, I'm feeling sad, or I feel angry. They also need somebody else on the receiving end of that to say something like, that makes sense. Well, that's okay. Why don't you come and talk to me about that? If people don't have enough experiences of that, maybe because people are not around, or it could simply be the way that other people have been parented too. I'm English. I come from a very kind of English upbringing where emotions weren't really too big, and there wasn't that much emotional expression. So there probably wouldn't have been too much emotional validation kind of around me growing up, because people just didn't really do emotions. So there's no bad intentions there, but that would mean that need of being able to express how I was feeling and be validated wouldn't always be met. A fourth need is actually to be able to have fun. So in life, we also need spontaneity and playfulness. And that, by the way, doesn't stop when you hit about 18 years old or so. That is a need that all adults have too, is to be able to let off steam, have fun, and be spontaneous. And then the last need is to have realistic boundaries, discipline, and limits. That one's a lot about just hearing the word no appropriately. No, you can't have ice cream for breakfast. You have to do the dishes before you can go on your PlayStation. So a lot of it is about appropriately hearing the word no. But sometimes that can be about somebody not having too loose boundaries. So, a child doesn't need to know all about the intimate relationship between the parents, or be the confidant to one of them. And of course, very, very unfortunately and very sadly, the biggest violation of boundary can be trauma. So if people have been abused, that is a need that has absolutely not been met. So with these broad categories of needs, the idea is that how well these are met when we're growing up does affect our development and develops the formation of what we call schemas. But it's not about perfectionism. So sometimes, unfortunately, if we or somebody goes through even just one bad enough experience, goes through a trauma, that can be enough to really have violated some of these needs and have an effect. But a lot of it can be about kind of repeated episodes of consistency. So like I said, if somebody simply doesn't get emotional validation, maybe simply because their parents are just not that emotional themselves, then that might mean that need doesn't really get met. So how well these needs are met when we're growing up affects things like schemas and our personality development. They still count as adults as well, though. So we still have these needs even as an adult. So we still need connection. We still need to be able to have fun. We still need to be able to open up to people and receive validation. But if we've had certain needs that have not been met that consistently when we're younger, it can affect how sensitive to that we are when we're growing up as well. So for example, if I've had a hard day at work and I come home and I say to my wife, look, yeah, I've had a really hard day. Can we talk about things? But maybe she's had a hard day too. And she says, look, could we not? I've had a hard day. Can we just watch some TV? If people have been there for me enough, it might still sting a little bit because I might be thinking, well, would have been nice to kind of talk about stuff. But I might also kind of get, look, not everybody can be there for you all the time. So if I've had a history where I felt like my needs have not been important, then what might go through my head instead might be great. You know, it's always the case whenever I need somebody, no one's ever there for me, they don't listen to me. So how well these needs can be met when we're younger, it also affects how sensitive we become to them being met or not met when we're older too. Hope that makes sense so far. Now, so I'm going to tell you a little bit about schemas, and I'm going to tell you a bit about how the borderline personality disorder perspective from schema therapy. So a schema then is a central, a core idea of seeing schema therapy. A schema basically is a very fixed pattern of something. It's a fixed pattern that involves thinking, that involves certain emotions, including where they sit in our body, and may involve memories that have created this. So a very, very common schema is what we call self-sacrifice. That is where people put other people first, usually to the detriment of themselves. So we all probably know somebody who is always giving, who is always there for other people. So essentially that person goes, other people's needs are here and my needs are here. Other people's needs are just more important. So as thinking, a thought may be something like, you should always give to other people, or it's the right thing to do to put other people first. The feeling when this schema is triggered may be guilt if you are thinking about putting your needs first, about saying no to somebody. You may feel that physiologically in your body, so it may be kind of butterflies in the tummy, your heart races a little bit. And then memories that the person may remember growing up and hearing that quite a lot from a parent. Oh, you know, you should always think of other people. Or they may have particularly strong experiences where they've now got a memory where that has really, you know, kind of influenced that. That's a kind of fairly non-too destructive schema. So that's a very common schema that a lot of people have, but it can still cause problems. With stuff like borderline personality disorder, we can get schemas which can be a lot more hurtful to the person. So for example, there's one called mistrust abuse. That is where the person expects other people to harm them in some way. They expect that people are out to kind of get them or are going to kind of abuse their trust. And if we look at the memories around that, they may have had experiences of people really breaking their trust when they're younger, whether that's some form of abuse, whether it's kind of bullying. So these memories, these earlier experiences will have really kind of created this. So, and one of the things with schemas, because you can have positive schemas, but in therapy, we're looking at ones that are maladaptive, so cause kind of harm. So we're interested in stuff that is dysfunctional, so it does cause the person problems. So everybody on earth has some schemas. What's important is which ones you have and if and how much problems they cause you. So I am a bit of a self-sacrificer. I do like giving. I'm there for my family, but it doesn't really cause me too much dysfunction. I know when to say no, you know, and I kind of know how to look after myself. And the origins, when we're looking at early maladaptive schemas, are in childhood or adolescent experiences. We can all go through things in adulthood as well, which, if it's impactful enough, is also going to create a new pattern in the way that we think and we feel. And in schema therapy, we're looking at stuff that happened when we were younger. Okay. One of the things that's important with a schema, though, is that we may cope with that differently. So to put it very simply, you know, some people will choose to cope by avoidance. So just to choose to say, not be in a relationship, because then maybe nobody will abandon them. If I'm not in a relationship in the first place, somebody can't not meet my needs. Okay. We might surrender. So that's where we may treat our thoughts and feelings as if they're true. So if someone has a sense of not being good enough, they may kind of act as if they are not good enough. And we can always do what we call overcompensate as well. With overcompensation, it is where we act the opposite of a schema. So that can be where someone actually deep down is maybe quite afraid of standing up for themselves. But instead they act all tough. They act like, you know, nobody can mess with them and I never let anybody push me around. So how somebody copes with their stuff essentially underneath does affect the behavior, affects how it looks on the surface. Now, schemas then are like traits. So schemas are fairly fixed parts of our personality. And originally, Jeffrey Young proposed that there was 18 different schemas. We now believe that there may be a few more, but there could be up to arguably about 23 different kind of personality traits in this way. But modes is a much broader term. So with a mode, it's more a state that you're in, so that it is a part of your personality that you may be in at a given point. And hopefully that'll become clearer when I explain the mode version of schema therapy. And the reason why we often use what we call schema mode therapy is that, for example, if you took borderline personality disorder, they can have up to all 18 schemas. And they can have them quite severely, so they affect them a huge amount. If I, as a therapist, was trying to help them with each of those individual schemas, it would be too difficult. It would take me too long, and we'd be switching our focus every single session from one schema to the next schema, to the next schema, to the next schema. So a mode is actually a much broader state that can encompass several schemas or patterns. So instead, I can talk about the vulnerable part of you, and that may include abandonment schemas. It may include schemas around defectiveness, around being abused. So instead, I can use a broader term. And to most people, the idea of having different parts of their personality kind of makes a lot of sense. It's often something that's very intuitive to people when you start to talk about it. So this is and I'm not very technologically gifted, so this is my PowerPoint version of what it is a typical stereotype idea of borderline personality disorder from a schema mode perspective. One thing that I will say, though, is that, you know, schema therapy is a very individualized therapy. It's about really getting to know the person in front of you, getting to know what schemas they have, their history, what's gone on, how all of this is formed. So this is a general stereotype kind of mode model that does not mean it necessarily applies exactly to the people that you know. The people you know may have slightly different schemas or slightly different modes. And borderline personality disorder can have up to 9 kind of symptoms or experiences if somebody's making a diagnosis, and you're actually going to need 5 of those to hit the criteria. That means there's something like 35 different combinations of all the different symptoms. There's actually a lot of different presentations of it. So thinking about it from this angle then, okay, if we look at the top left-hand corner, so as I was saying, schema therapy from a mode perspective is about the idea that we all have different parts of our personality. What's important is what parts we have and if they are helpful or cause us problems. One part that every single person on earth has is what we call a vulnerable child part. We are all born into this world vulnerable. So very broadly, that is the part of us that contains vulnerable feelings. It's the part of us that can feel sad, that can feel lonely, that can feel afraid. So our vulnerable part is the vulnerable feeling center, so to speak. And it is there since day zero. And when somebody is really in their vulnerable part, we can actually feel emotionally younger than we are. So it doesn't matter if you're 40 years old, 25, 60. If you get this part of you triggered, so you're in your vulnerable child mode, you may feel like a 6-year-old little girl who's about to be abandoned. You may feel like an 8-year-old boy being told off again, even though you're a CEO of a big company. So this is the big feeling center, and people can feel emotionally younger when they're there. Okay. Now, the core schemas, so the core traits of somebody with borderline personality disorder is abandonment and what we call defectiveness shame. So abandonment is the idea that ultimately people are going to reject or leave me. And schemas exist on a continuum. Someone can have it from slightly milder form to something that's very, very severe. So in a more severe form, someone can genuinely believe, even if I've had a partner for 30 years, at some point now they're going to realize that, I'm not good enough and they're going to leave. With that, it's obviously very difficult for the person to experience times away from the other person. And things like even in therapy, if I go on holiday in therapy for a couple of weeks, some of my clients have a really strong version of this, will genuinely be worried about if I'm going to come back, or if in some way, shape or form, I'm just not going to. Defectiveness and shame means that deep down, the person doesn't feel good enough. And that's where the shame part comes in. They feel almost like that they are shameful, that who they are is not good enough, is broken in some kind of way. This can often be linked to trauma, because with trauma, that can often be very shaming, and the person, unfortunately, when they experience it, often takes on the shame. Or in some ways, it may be that through things they've missed out on, they kind of just feel like they're not good enough. So that's a kind of stereotype version of the vulnerable child. We'll say my vulnerable child will look quite different to that. I would have different schemas. Now, there's another mode that everybody on earth also has, and that's the angry child mode. We all get angry when our needs are not being met, or when they're being blocked in some way, or somebody is not treating us well. So the angry child part of us, in terms of this, we say sits right next door to the vulnerable child. It's there to throw a tantrum and to protest when our needs are not being met. But when someone has this in a problematic way, it often then turns up like an adult or somebody throwing a tantrum. So when somebody goes into this part, they may say things that are very hurtful. They may literally break things. This may be the part of them that sends text they really shouldn't have said and they're going to regret. So we kind of talk to people about, your anger itself may be kind of valid or understandable, but this part of you does not communicate it in a healthy way. This part of you, when you become kind of explosive, it causes problems. Okay. But we don't talk about everybody's angry child, because not everybody has an anger problem. So even though everyone on earth has an angry part of them, we only really talk about it if part of their presenting issue, part of their problem is kind of anger in that sense. Then the last part, which we also see is what we would call a child mode in schema therapy, is called the impulsive child. So this may be the place where somebody does things like self-harming in an impulsive manner. Maybe they kind of take drugs. Maybe they do something else that's just kind of based on impulse that again is going to cause some problems. So all of these in blue are what we call different child modes. So they can be there from quite young. Now, the one in green in the middle is about coping. So in borderline personality disorder, the main way of coping with all of this essentially is avoidance. And it's what we call the detached protector. So this is a part of the person that essentially, maybe from when they were younger, and it could be that they felt that they couldn't open up to people, or that, people didn't want to listen to them if they had emotions, but essentially copes by saying, don't feel emotions, don't show them, maybe minimize what's going on for you. It's almost like putting on a front with a person saying they're okay and they're fine, even when they're not. So if someone has a strong detached protector, it's kind of like they don't want the vulnerable child mode triggered. They want to pretend it's not there, that this vulnerable stuff doesn't exist. And a lot of my clients with borderline personality disorder would often kind of say that emotions are not helpful, and if they could just get rid of them, they would. And that's often kind of this part of them. It's a way of coping by trying to not feel things. And there may be specific things that someone does to try and push away emotions, like kind of take drugs, take alcohol, things like that. But unfortunately, this part of the person ultimately leads to more problems there. Because trying to pretend that you've not got feelings, or that they're not there, doesn't actually get rid of feelings. It doesn't actually deal with the problems. It just means that the feelings and the problems are still there underneath the surface, building up until they bubble over. And that's where you might get kind of a lot of emotion coming out at once. It's often because it's been pushed down, ignored, and pushed away. Whereas if somebody can learn to feel emotion when they're feeling it, learn to express it in healthy ways, and learn how to deal with it, then you actually don't, ironically, get as much heightened emotion coming up. The other thing that often people will have with borderline personality disorder is quite a self-derogatory way of thinking. So, and you may even hear them out loud say stuff like, oh, I'm such an idiot, I'm so pathetic, no one would love me. So it's kind of like they've got this self-abuser in their mind. And we call this the punishing critic in schema therapy. This is the only part that we would say probably has no useful function. And it is almost like just self-bullying and self-directed anger. And the last thing I want to point out on here is what we would call the healthy adult mode. So particularly at the start of therapy, someone classically experiencing borderline personality disorder will have a very strong vulnerable child mode, where they feel lots of vulnerable feelings. Because they often will then detach and not feel them, they don't know how to deal with their feelings when they have them. They may have anger problems and impulsive behaviors, and they may have this kind of internalized critic. What we're trying to do over the course of schema therapy is also build up basically their internal healthy adult. So a part of them who can kind of know that it's okay to have feelings, learn when to show them, when not to show them, learn how to deal with them, knows to learn limits, so we can't always act on impulsive behavior, to express anger in appropriate manners, develop a strong sense of identity. And in contrast to this internal critic, to be able to develop more self-compassion. So instead of telling themselves that they're an idiot or they're a moron, just to be able to kind of go, you know what, I made a mistake. Everybody makes mistakes, and that's okay. So to learn to treat themselves a lot nicer, essentially. Person with borderline personality disorder might look a bit different to that. And like I said, it's a very individualized treatment that really is about what's happening to you and what do you have. Overall, though, in schema therapy, what we're trying to do is we're trying to help the person best recognize what their underlying emotional needs are and their emotions, and learn how best to express them and to get these needs met in healthy ways. We want to be spending, as a schema therapist, the most time with that vulnerable child mode, healing it through things like imagery rescripting, which I'm going to show you an example of, and also through the therapeutic relationship. Being kind, being compassionate, being validating, helping them solve problems. And in doing that, at the same time, we're also trying to increase that healthy part, an internal sense of I can do things, I am a good person, I have worth, and increase their happiness. And we might also be having to work on that critic to decrease that, to make it less harmful in the person's life, and also get them to reduce kind of impulsive and anger-driven behavior. What that means is schema therapy is a very flexible therapy. So I need to meet the person where they turn up in a given session. So it's not incredibly structured in the sense of session 1, we do this, session 2, we do this. And it also includes a lot of them, what we call attunement. So really sitting there and understanding what is going on for my client, that person in front of me, and helping work out what to do about that. Whereas other forms of therapy might be more, we learn these skills irrespective of what's going on this week. In this week, we learn this. So I just want to tell you a little bit about some of the things that we do to try and help people change before we take questions, okay? So schema therapy does have 4 different broad areas that we use to try and help the person heal. So the first is, like I mentioned, the therapeutic relationship. That's often what we call limited reparenting. We are trying to provide those emotional needs within appropriate boundaries of the therapeutic relationship. That's the limited part. But we're trying to act essentially as like a good parent would. So when they need validation, provide validation. When they need to hear that the way they're behaving is not okay, to tell them that too. And that can be very healing in its own right for someone with borderline personality disorder, because things like if they've been through trauma, the fact simply that I am opposite them as a caring human being who is not hurting them, and the opposite is not shaming them, but validating them in its own right, can challenge some of their views of people in the world. We also use a lot of what we call those effective techniques. So the big 2 is imagery rescripting and chair work. We will also use any of the techniques from CBT. So things like challenge the way somebody thinks, get them to try and look at situations a bit differently, and also get them to act differently, to change their behavior. But the second 2, cognitive and behavioral techniques, are not as big in schema therapy. We emphasize more the therapeutic relationship and the emotional change techniques. So I just want to spend the last few minutes before we take questions on one particular change technique, which is imagery rescripting. Okay. So I'm going to tell you about imagery rescripting, then I'm going to show you a very short example of one. So in imagery rescripting, what we ask somebody to do is essentially to close their eyes and to bring back to mind an experience which has really affected them. So if we're working on any therapy, it's usually had quite a negative effect. So it could be some of the trauma that they've been through. Or it may not be quite as deep, but it may be something like if they have the idea, for example, that they're worthless, we might be asking them, well, where did you first learn that? What experiences have you had in your life that have taught you and made you believe that you are worthless? And they may close their eyes and start to go, well, I remember when I was 6 years old. So we ask them to bring back to mind kind of memories and experiences which have really affected them. And we ask them to tell us the experience as if it's happening again right now. So in the first person present tense, tell me about where you are and what's happening. What's really important in imagery scripting, though, is that we don't let whatever happened the first time around happen in the imagery. So if someone hurt them, we don't get to the point where the person hurts them. Instead, what happens is we pause it at that point, and then we change the image. So for example, it may be that I come in as a therapist and protect them from harm, or tell them that they are worthy, that, that they're good enough, that they have a nice sense of humor and they're a good person. And that's about providing emotional healing. So the reason why this works is that in your brain, the same areas light up when you have a real memory and also when you have an image. So we can open up memories and provide healing. Now, the thing is, the person always knows what really happened, but it's about giving them the emotional experience that they deserve to have happened the first time, And that does over time begin to change the way that they feel. So for example, if we're working on that sense of worthlessness over sessions, they'll actually just start to feel more worthy. After doing enough imagery rescripting, they'll just start to feel more like they do have worth and maybe they are good enough. So it's a very, very powerful technique. And one of the techniques that people always can report is really beneficial and is really helping in the therapy. So what I'm going to do, and I'm going to take questions, is show you a very quick example of this. So this is only about 4 minutes, which is ideal for presentations. In reality, most of the imagery scripting I do with people is more like 20 minutes or so. But this is very good as an example. Now, this is not a real example. This is an actress who this was for the purpose of training all the therapists to do imagery. So this was for an educational DVD. Okay.
Okay, so I just want you to close your eyes and I want you to get an image of that memory that you spoke about when Dad lost it at you for dropping the drink in the car. And you're in your room and he's taken off and he said, I'm going to come back and teach you a lesson, yeah? Just to bring it to mind, what do you see? Try to be that little 6-year-old girl.
Just sitting on the end of my bed.
Yeah.
Got some toys. I'm not playing, I'm just sitting there looking at the door.
Yeah.
Just waiting for him to come through the door.
Yeah, okay. And how are you feeling?
I just feel really scared, sad, alone.
Yeah, yeah. Can you feel it in your body?
Yeah.
Yeah, okay. And what's running through your mind?
Oh, he's going to come in, he's going to yell, he's going to just be so loud and he yells for hours. He's always so angry.
Okay. So just let this image play forward into the point where he's coming into the room, yeah? And he's being horrible. What do you see?
Just him, just big and red and loud, and just all I can hear is, you're always doing stupid things, it's all your fault, you do everything wrong, I'm gonna have to fix it
so
again.
Pause the image, okay? And I want you to bring me into the image, okay? Me now. Okay, and I'm there and I'm standing between you and little Nikki. And maybe, do you feel like you might want me to be bigger in size? Like, can you imagine, would that help? Okay, so you can make me bigger, so I'm sort of taking up a lot of the room and a lot taller than him and a lot bigger than him, yeah? Okay. And I'm there in front of you and I'm going to speak to your dad and I'm going to say, you are going to stop right there. I am there to protect little Nikki and I'm not going to let you have a say anymore. The game is up. We are running the show and you are not. What is wrong with you? I'm never going to let you harm little Nikki ever again. How's he responding?
Just really angry. He's really angry at you now. He's just yelling at you as well.
Okay, and I'm going to say, you can stop right there. You can stop right away. I'm not interested in you being angry with me. I am interested in Nikki, and I'm never going to let you have a say. And in my right hand, I have a pager for the 2 police cars that are outside. Okay? How's he responding?
He looks angry,
but
angry and worried.
Okay, and what do you need? Do you want me to bring the police into the image? Okay, so can you see me? I'm pressing the button, okay, the page for the police outside. And the police are coming in and storming the building. Yeah?
Yeah.
Yeah? Okay. And what do you see?
His dad's being angry with them, shouting.
Yeah, and how are they responding to him?
They're putting him in handcuffs.
Yeah, okay.
Pulling on him.
Yeah, okay. And I'm going to say, Dad, you've met your match. You are not going to have a say anymore. You are not going to hurt little Nikki anymore. The police are taking care of you. And what are the police doing?
They're dragging him out.
Yeah, okay. And how are you feeling when that's happening?
I feel good.
Yeah?
Yeah.
Yeah? Great, okay. So what happens next? Can you see what happens next?
They're gone.
Yeah?
The doors.
Yeah?
Doors open, but they're gone now. It's
okay. So he's gone. The police have taken him away. Okay, and how are you feeling?
just less shaky.
Yeah.
Not scared.
Yeah. Okay. Okay.
Okay. Just before we take questions, that's just a very small example of one kind of example of imagery. Imagery you do with people really differs, depending on what they've been through and their circumstances and stuff. So that particular scenario, the idea was that, you know, the person had actually had a very kind of violent and aggressive dad. And what the person really did need was for safety, you know, for things like that to not happen. And, you know, I'd always wanted someone to actually, like the police, to know what was happening and stop it. So in that sense, it was about meeting the need. Whereas other forms of imagery may simply about being with somebody. So maybe they're really lonely as a child. So you come into the image to say, you know what, it's okay, I'm here. You know, I want to hear how your day's been. So it really differs. It differs depending on what the need is, what the image was at the time. And as you can see at the end, it's about the person getting the felt sense of it being corrective. So her feeling safe, her feeling like she was protected. And that's what someone kind of takes away from that kind of experience, which can therefore be very, very powerful. So I'm going to stop sharing my screen with you. That is my absolute nutshell kind of version of schema therapy. So we'll take any questions.
Okay, I think I've opened up the group chat. Is everyone able to chat in there? Please feel free to pop in any questions. Chris, would you like me to read out a couple of our pre-submitted questions?
Yeah, look, I can see there's a fair bit
yep.
about difference to DBT.
Yep.
So look, and I'm trained in both, and I deliver both DBT and schema therapy. Look, they're very different therapies which approach things very differently. And in my opinion, they can also be very complementary. So a couple of very key differences is that DBT is about, you know, really helping people gain skills. And without kind of going too much into it, essentially, look, DBT has different stages. What people often think of as DBT is where we're trying to help somebody learn how to emotionally regulate more. And it may be that at that point in their life, they're doing things like self-harming and they're feeling quite suicidal. So DBT's approach is, you know, when people are feeling that way, we really want to teach them skills to help them deal with the stress better and be more regulated. What doesn't happen at that stage of DBT, though, is the kind of like, okay, but why do you feel this way? You know, what's happened? What have you been through? Which is making you feel really distressed, which is causing these feelings. And in that sense, DBT at stage one is very present focused and is focused on behavior and skills. Schema therapy is more about what has happened to you, what have you been through, why do you feel this way? And in that sense comes in more interested in the past. And if somebody has the emotional capacity, because it's always about someone's window of tolerance, you don't want to harm somebody, you know, you don't want to be opening up stuff that somebody cannot handle. But the kindest thing to do from a schema therapy perspective is if the person has been through experiences, which is why they feel so afraid, why they feel so worthless, is to do things like focus on that and help that heal. And in that sense, schema therapy comes from a bottom-up approach, whereas DBT goes from a top-down. My opinion is that just different people will better benefit from the different styles of therapy, maybe a little bit depending on where they're at the time, and just what's going on. So some people really need that skills first and really need to help to get more regulated and be taught stuff in that way, maybe even in order to tolerate things like imagery rescripting. Whereas some people very much already have good enough coping skills and might really benefit from going and doing the deep work. My experience in doing schema therapy is that if people have done particularly what we call the distress tolerance skills from DBT, that they tend to tolerate it better. So they're just different forms of therapy. And there was a question along that. Let me just go back to it. So in that sense, look, if someone has done a DBT course first, then it might be that they might benefit more from schema therapy. But it really, when I'm getting to know any single individual, that's the thing, I'm getting to know them individually to think about stuff like, do you need DBT? Do you need the skills first? And then we may do schema therapy. Whereas some people will think, I don't think you do. I think you are, even though you've got distress, you've got enough coping and enough support. So let's go and do the more like imagery type work. But yes, it can be a good idea to do DBT first. Hope that answers that. Okay. All right, let me see the next question. Recovery from BPD is a very big question. I'm trying to think if I can do that justice in a few minutes or whether we kind of skip that one. Look, somebody can recover from borderline personality disorder, absolutely. But that depends on the severity of what they've been through and the severity of their current symptoms and just sometimes other factors, like if they can engage in the therapy for quite a long time and things like that. And if life is stable enough to be able to really concentrate on that, or there's lots of other stresses going on. But absolutely, I have worked with people who at the start of treatment meet the criteria for borderline personality disorder and at the end would not meet the criteria for borderline personality disorder. Yeah.
We also have a fantastic webinar up on our website from Dr. Louise McCutcheon, who talks a bit more about recovery rates from BPD, especially where there has been some early intervention or some therapy that the person has been able to access as a young person. There's a lot of really good results.
Yeah, thank you. Looking at boundaries, you asked someone's asking about boundary issues to do with the therapist coming in. Look, somebody may have boundary issues in that sense, but even then, I can tell you it's rare, and I will just deal with it as a therapist, because the benefit of me initially coming in as a therapist, one is I know what I can say and do, so I'm in control of that, and it's about, in the image, the person is in their vulnerable child part. They're not able to necessarily think of what they need to happen or kind of conjure that up themselves. Ultimately, in imagery rescripting, we're trying to get them to the phase where they come in. The client comes in as the adult version of themselves and stand up for themselves. That's huge for self-empowerment and self-efficacy. So we're initially providing a model of that, a model of caring, a model of someone standing up. If someone then gets confused about what that means, then that's part of what I deal with in the therapy. I'll explain the limits of the therapeutic relationship, what I'm there trying to do for them and stuff like that. But it's fairly rare, and it's still better to do it than to not do it because you're worried that someone may take it the wrong way. In terms of changing adult tantrums, okay. So that's going to depend on why they're throwing a tantrum, because I'll tell you more broadly that anger comes up in about 8 different places in schema therapy, but assuming it is the angry child, that's a combination sometimes of skills. So actually, particularly from DBT, there is a phenomenal skill called stop that is one of the best skills I think out there. And if someone can learn to do the stop skill when they're about to lose it and throw a tantrum, that is one of the most helpful things to do. And more broadly, it can be about helping them understand earlier why they're getting angry and learn things like, and again, with the DBT skills, how to express that, how to be assertive with people instead of getting to the stage where they're kind of exploding. So from our perspective, if someone keeps on throwing a tantrum with us, at that point, it's often about limits. You know, whether that is kind of like, look, I want to hear what you've got to say. I take it really seriously, but I can't listen when you are. And it may be if it's, you know, being abusive or, you know, kind of shouting at me like this. So I really do want to listen, but I'm going to come back and let's talk about this later on. Depends on exactly what's going on, but it may be about the point of a tantrum, about kind of setting kind limits. But trying to help from therapy, develop other skills and express anger in a healthier way. If somebody, this is probably the hardest thing in therapy, okay? If somebody simply does not want to open up. very sadly, I can tell you that somebody could have the most skilled therapist in the world, but you cannot help somebody who does not want to open up and get help. This is not a schema therapy specific term, but we often talk about what the therapeutic hook is for somebody. So why are they sat opposite you? What is the thing that is making their life unbearable? And sometimes we do have to try and find that to help somebody realize that they do need to change, that they do need to make differences, because their partner's going to leave if they don't stop doing X, Y, and Z, you know, because they're going to end up in jail if they carry on doing this. It really honestly depends on what's going on. A lot of the time when people are not open up in therapy, it's actually because of the really tricky schema called mistrust abuse. Even though they're sat opposite me, and in that sense, you might say there's a part of them that knows they need help and is willing to be in the therapy. There's also another huge part of them that doesn't trust me, that feels like if they open up to me, I might hurt them in some way, I might abuse their trust. So that might be about time. That might be about being willing to sit in silence with them, you know, to try and gain rapport in other ways, to kind of demonstrate, you know, over a few sessions that I'm consistent, that I'm not abusive, I'm nice, and for them to start to open up little by little. If it's that's often just time and patience, but also doing what we call claiming the trust. So at some point going, hey, we've been meeting for 10 sessions. As far as I'm aware, I've not done anything that is harmful or hurtful. I've been here every session, I want to help, but you need to start opening up if you want me to help you. And I think there's a part of you under there who does want help. I think there's a part of you who for life, it is unbearable, but I can't help that part if you're not willing to open up to me. It may be in that sense a bit of a detached protector. I'm sitting with a wall in the therapy, so I've got to be able to name that and try and get it out of the way. But ultimately, if somebody really does not want to open up, I will empathically confront it, as we say, try time and patience, but it may be that they're just not ready. It may be that they're not at the point yet where they're ready to open up. And it might be that it's unfortunately the next therapist who they might be more willing to open up to. But it's one of the hardest and unfortunately saddest things. But you can't make you can take the horse to water, but you can't make the horse drink if the horse doesn't really want to. I'm aware of the time. Would you like me to answer a couple more? I've probably got a few more minutes, or do we need to really finish up?
We could probably have, another 3 minutes or so, but I'll just close the chat as we won't be able to accept any more questions. Okay. Is there any particular question that is standing out to you, Belinda, or that you would like me to answer? So look. We have had some more questions about recovery. Can if it's okay, I'm going to answer the question about PTSD, because this is, I think, quite an important one for people. Okay. So one of the things with therapy, and this can be any real deep therapy, whether it's DBT, schema therapy, EMDR, or other things, is that sometimes things actually kind of feel like they're getting worse before they get better. Particularly if someone has coped by trying to not feel and tried to put away their experiences and pretend that they didn't happen. Coming to therapy and having somebody like me ask them how certain things make them feel. Maybe ask them things like, where did you learn that? May mean they start to get attached more to their feelings, start to get attached more to their symptoms again. And I don't think any other clinician are ever doing that to try and hurt somebody or cause harm. In therapy, you need to feel to heal, essentially. What you are trying to do is provide a safe and therapeutic space and container for what the person brings in and what may start to come up with them to be able to talk it through, and maybe even work on stuff like imagery, potentially EMDR, maybe other stuff if they need to. What that does mean is that people can do what we call emotionally fall, where their symptoms can get worse, they may get more distressed,
they may actually start to have more PTSD type symptoms because they're now coming to therapy and opening up and getting attached to things. In good enough therapy, though, that will be part of the process, and will be support to then also help the person contain that and deal with that. So that ultimately, it's kind of like if you've got an arm that's broken or something and it's set in a way that's not good, you may have to go in, open up the wound in order to heal it, clear it out, and reset it. So I hope that makes sense, because it is a really important thing that people can experience, almost like feeling worse. So I think people also, it is okay for people at times to go, is now the right time for me? I do have trauma, I do have difficult experiences. And maybe, at some point I do absolutely want to work on them because this is affecting me, this is affecting my life. But it's also okay for someone to go, this is going to make me more emotional. This is going to make me more distressed. Do I have the capacity and support in my life right now to do that? Or do I need to do things like work on coping skills first, get more support around me, get through this stressful situation before I look at this deep stuff? And I hope that makes sense.
That is wonderful. Thank you so much, Chris.
No problem.
It has been a really enjoyable presentation. I hope our audience have enjoyed too, learning about schema therapy. Your questions were many, and we do apologise. We try very hard, but we can't get to all of the questions. We do encourage you, however, to have a little look online, delve a bit more into schema therapy, and see if it might be something that's right for you or your family member. I'd like to say a really big thank you to our wonderful presenter, Chris, for your dedication to this faith and for volunteering your time today to share your knowledge with us all. And a big thank you to our audience, as always, where we think that you should give yourselves a pat on the back for showing up for yourself and your family. And we so appreciate the generous donations that have come in. I have put a donation link there in the chat. If you have found value in today's presentation, we would be so appreciative if you could give us a little bit of a donation. That would be wonderful. I've also put our email address in there, so if you've got any queries about our Family Connections programs, please email us there, familyconnections@bpdaustralia.org. I will send out further information with the recording of how you can register, how you can get in touch with us. And the recording of this presentation will go out in the next few weeks. We have very stretched resources. We do the best that we can. Unfortunately, we cannot send attachments or the actual slideshows, but we will send you a link to view this presentation, in which you can pause as you go through each of Chris's very informative PowerPoint slides. So thank you, everyone. It has been fantastic. Hope you all have a good night.
Thank you.
Thanks, Chris.